Hello, everyone. So my name is Peter Monteleone. I'll start off by mentioning that some of these slides are actually created by Dr. Josh Beckman at Vanderbilt. He's a brilliant scientist and clinician, and it's an honor to discuss his thoughts and my thoughts together. We'll be cycling back around in general to the first talk of this symposia, talking about medical therapy and PAD, particularly focusing on enough for 6 different topics: SGLT2, PCSK9, and Rivoroxaban for PAD, when and where. As was mentioned in the first talk, if you look for PAD, you find it everywhere. You know, it's obviously an incredibly common disease in asymptomatic and symptomatic populations. You'll see percentages of folks in their 70s at 15 to 20%. If you find it, it means something, and we've known that for a long time. So with people with PAD, even asymptomatic with a lower ABI, they have a significant elevation of their cardiovascular 10-year mortality, regardless of their Framingham risk score. Their 5-year mortality, if they have claudication, as high as 30%. If they have CLI, even higher. PAD populations that are asymptomatic also carrying these elevated risks. And so beyond the limb, as we talked about early and will continue into now, beyond devices for revascularization, we need to continue the excellent focus that's been placed on medical therapy for decreasing the adverse cardiovascular events that really can cause the mortality in these patients. So with regards to lipid therapies and novel lipid therapies, we've known for a long time that statins are important for patients, particularly patients at high risk with PAD. We saw that in heart protection study and in the large Netherlands outcomes group. What we saw a little more recently in 2014 is actually statins improving outcomes in critical limb ischemia. We actually see improvements both in MACE, but also in the combination of death and amputation just with statin therapy. More recently, we've started looking at the addition of PCSK9s, including evolocumab, on top of statin therapy. So in 2017, we looked at that addition in patients already on statins. We learned a lot of things from this paper, one of which is we learned that we're not very good at giving statins to patients with PAD. When we looked at this population, again, we were seeing not patients that all of them should be on something, 60% of them were. The main topic of the paper was that addition for optimization of therapy, further driving down LDL levels with PCSK9 medicines, improved everything including major adverse limb events, as well as major adverse cardiovascular events. And if we look at MACE in particular, combining MACE and MALE, you see that the PAD population had a dramatic improvement in that combined therapy, even well beyond the patients who were free of PAD. So there's something special about this patient population that benefits from that combined therapy. We heard a lot already of an excellent discussion and analysis about Rivoroxaban and the COMPASS trial. I'll do a little bit of that same combination. We already heard about how Rivoroxaban compared aspirin to Rivoroxaban and low dose plus aspirin. And as discussed, we saw this improvement significantly in cardiovascular death, MI, and stroke. We also saw, particularly in these patients with stable PAD, an increased improvement when we combined adverse limb events with adverse cardiovascular events. So for the reasons discussed previously, this combination therapy is really dramatically improving outcomes in these patients. When you look isolated to major adverse limb events, we see the same thing. So not just cardiovascular events, but also helping with limb events in these patients. And it was across subsets. We see it in smokers and non-smokers and diabetics and patients with coronary disease. We see it in everyone across the board. And those numbers were real numbers, and we went through those risk reductions that existed across groups. As noted previously, this is an anticoagulant medicine. This is an anticoagulant medicine being studied in a patient population free of high risks of bleeding, and yet we did see an increased risk in bleeds, including an increased risk of major bleeds. Depending on the calculations that were done, number needed to harm for major bleeds were somewhere in the 84 range. Number needed to treat for decreasing of MACE was somewhere in the under 50 range. So it is a combined risk that we think about, as we focus in on these combination therapies. With regards to novel diabetic agents, we think about GLP-1 agonists, and we also think about novel SGLT2 inhibitors. And so these medicines in particular for diabetic patients as second-line therapy after addition of metformin have a lot of added benefits in these patient populations, from improvement of control of A1Cs to weight reduction to also avoiding those hypoglycemic events. And when we focus in on the CLI and the PAD populations, we saw when we were looking at liraglutide, a GLP agonist, actually an improvement in amputation risk, and some improvement, though not significant, in infection of underlying structures and peripheral revascularization. But then when we look at this cohort with canagliflozin, a novel SGLT2 inhibitor, we actually saw this alert regarding increased risk of amputation, small amputation at the level of the toe and TMA, but amputation nonetheless. And in a patient population at high risk for that, we certainly need to be thoughtful. So we know that these novel agents, by comparison to some other second-line PO agents for diabetes, improve MACE, but we are at least a little bit thoughtful about this signal we saw with SGLT2 about increased risk in amputation. And it was present in patients who've had amputations before. It was present in patients with or without peripheral vascular disease, and it's something that we think about as we're looking at highlighting strategies for medical optimization of these patient groups. I left Dr. Beckman's summary on here as well as mine, just because I certainly didn't want to misrepresent him. He said low-dose Rivoroxaban should be used now, and we'll have data about revascularization to use it in people immediately after, as we talked about with Voyager coming down the line. He talked about this caution with SGLT2 used in individual patients for specific reasons, and he talked about PCSK9 inhibitors being indicated in PAD patients. And you know what? You may get a leg benefit too. With regards to my summary, quite similar. You know, we absolutely can use it now, and I do use it now. If you're not using it already in at least your high-risk population, you should be thinking about it. You know, there's remarkable numbers, some of which we saw, for decreasing risk of stroke, particularly with folks with carotid disease. And folks who've had thrombotic ALI events, there's no reason not to be thinking about it. And we'll likely be continuing to expand this, being thoughtful about the increased risk of bleeding that occurs with it, both in patients with stable PAD and hopefully soon in patients after revascularization. With regards to SGLT2 inhibition, again, MACE benefits are there, and they're there dramatically, but some caution in these PAD patients regarding signals we've seen with regards to increased risk of amputation. And then for PCSK9 inhibitors, I'm just as excited as Dr. Beckman was. So this concept of really thinking about these patients, not just for the MACE improvement, but also for the lower extremity benefit as well.
Thanks, Peter. That's great. And maybe what we'll do is take 2-3 minutes, and I'll just go down the panel here, because I think we've gone through the medical therapy portion of the thing of our conference, and then we're going to get into some of the procedures, devices, and things we can be thinking about in our peripheral labs. So let me just go down the panel and ask people, how are you deciding which and when of these new therapies to use? And if you don't have an order, is there some standard way in which in your practice you're incorporating them? Maybe I'll just start with Peter or Kinto.
No, please. So I think the major limitation is, the patient population that we take care of, and implementing this current data, it becomes kind of limitation because of the cost involved in this newer medication. So I definitely have to take that into consideration almost all the time in my patient population, irrespective of the newer trial data.
You know, it's interesting. One of the things about PAD is sometimes PAD lacks the true capture event that cardiovascular disease has or stroke disease has. And so when someone comes in with a leg that's hurt for the last 10 years, it's hard to convince them they need to be on an anticoagulant now, as opposed to someone who comes in with a stroke or heart attack. So we certainly started with those higher risk populations, those patients either who've had thrombotic events previously or have a carotid stenosis on top of their PAD, and we could talk about stroke benefits. But with cost considerations as well as risk considerations, we're kind of moving slowly towards increase, at least for Rivoroxaban. PCSK9s have bumped into that same consideration with patients about, my primary care doc said a statin is fine and this is expensive, my insurance doesn't cover it, and it's injectable. But I think that message is slowly starting to diffuse through the levels, and we're getting there.
So let's just get an opinion from all the panel as well as from the crowd. How many of you have routinely started prescribing Rivoroxaban for patients of PAD? So we have at least few people who have started that, but as we can see, everybody's finding it's a little bit difficult to implement this data into the practice. Now it's out for a few months. So, Raj?
Yeah, I think, if you asked me that question 6 months ago, I would say I've been kind of slow to uptake some of the evidence into practice, but I think more and more I'm doing that more. I think the biggest issue for the practice where I go to do a lot of PAD work is cost and compliance. And a lot of these patients also have other comorbidities that put them at high bleeding risk. So I'm always trying to balance that too. So, but at every visit now, I look at the medication list and see what can I add on or what can I optimize.
So I think there's two pieces that we're always thinking about in patients with PAD, and one is preventing major adverse cardiovascular events, and the other is thinking about the limb. And what's really exciting here is that we finally have some medical therapies that we can think about in terms of directing towards the limb. In terms of major adverse cardiovascular events, it really looks like the highest risk people are those polyvascular disease, which is kind of echoed through a bunch of these talks. So those are the patients I think I would think about overall intensifying therapies that address major adverse cardiovascular events. With regards to the limb events, the major adverse limb events, if you look at most of the studies that are looking at this, the highest risk people are those that have undergone revascularization in the past, whether that's endovascular or surgical revascularization. Now, of course, we don't have the data for immediately post-revascularization, but even in the chronic state, those are the people that have the highest risk. So if they're not on anticoagulation for another indication before, I'm targeting thinking about Rivoroxaban to those, or these limb prevention therapies to those people.
I'm still not sure I understand how Rivoroxaban works for those patients in terms of decreasing stroke risk. Is it carotid atherosclerosis, or is it embolic risk from the arch or from a central source? So anybody in the panel have some insight into the mechanism?
That's a great question. And I think the reason we're seeing, one of the things is why is there such a big benefit in general? And I don't know the answer. I guess I would say that if you look at non-AFib stroke, at least half of it is in the vessels that are between 2.5 and 3.5 millimeters in the brain that one might imagine have some of the same atherosclerotic properties that are going on in the brain with different properties. And then, of course, feeding into that is the carotid that does have artery-to-artery embolization. So when I talk to the stroke neurologist, as a cardiologist, my understanding of stroke is very limited as most, I would say. But when I talk to the stroke neurologist, they believe at least some part of it is the same atherosclerotic benefit that might happen in the vessels. In the stroke literature now, there is some dual antiplatelet therapy acutely for stroke, followed by some monotherapy, and then it's acute therapy. So I think they're following us in going into the vessels around the same size, doing some of the same things we might have thought about in the coronary. At least that's best explanation I have. One more comment, and then we'll get on to our next.
Yeah, so I was just going to say, I think in the highest risk patients, this may make sense, but the biggest limitation, I think, really is the cost. And if you've got so much polypharmacy in these patients to begin with, and then you're adding a drug that puts them into the donut hole quicker. And so I think you really have to look at, we know that PAD patients are undertreated to begin with, so I think optimizing their initial treatment is a huge process, and getting them compliant with the initial therapies is the biggest challenge. And then once they're at that compliance level, if you have the opportunity to add a, if you will, less affordable, potentially, or additionally beneficial drug, that's great. But I think that's one of the biggest issues is, if they fall in the donut hole 6 months in, what do you do for the last 6 months?
Yeah, I think it's a great point, just to highlight that 50% of PAD patients are not on statin or lipid therapy in some registries, so we shouldn't certainly think about new therapies till we institute the existing ones to the best